Hello everyone, this is Dr. Midun. I'm doing super specialty in critical care after anesthesia. So this is my new channel and this is my first video. So we'll discuss about different types of cases here. For now, we'll discuss about paracetamol poisoning or acetaminophen poisoning. We'll discuss about a case. She's a 17-year-old female. She has reported ingestion of 40 gram of acetaminophen 4 hours prior to admission as a self-harm attempt. The patient had several episodes of vomiting and is now sleepy but will wake up and answer questions. Her vital signs are within normal limits and her examination is unremarkable other than her somnolence. Her blood chemistry and transaminase are within normal limits, but her acetaminophen concentration is 430 mics per ml. So we'll come to paracetamol poisoning. So acetaminophen has antipyretic and analgesic actions, but with very weak anti-inflammatory activity, and it is the most widely used over-the-counter analgesic agent and antipyretics in the world. And it is a major cause of overdose and overdose-related liver failure and death in the United States and many other countries. It is rapidly and completely absorbed from the duodenum. The peak serum concentrations is achieved at 4 hours. The maximum recommended daily dose of acetaminophen is 3.25 grams. So we'll come to normal metabolism of paracetamol. So paracetamol, 5% is excreted unchanged in the urine, 90% undergoes hepatic conjugation, glucuronidation in adult and sulfation in children, and to become the non-toxic moieties. 5% undergoes oxidation by the CYP 450 CYP2E1 system to become NAPQI, N-acetylcysteine, and which is toxic, which is detoxified by glutathione and becomes non-toxic metabolites and excreted in urine. So what happens when there is overdose, paracetamol overdose? When there is overdose of acetaminophen, the acetaminophen, which is converted into sulfated conjugates, non-toxic sulfated conjugates, that pathway gets saturated and it will be diverted more to this pathway where there is formation of more toxic metabolite. And when there is more traffic in this pathway, the N-acetylcysteine, the glutathione gets saturated, and there will be more formation of non-toxic metabolites. So coming to the toxic dose of acetaminophen, single acute toxic dose of acetaminophen is more than 200 milligram per kg in children. Repeated supratherapeutic toxic doses, more than 200 milligram per kg over 24 hours, more than 150 milligram per kg per day over 48 hours, and more than 100 milligram per kg per day over 72 hours. So coming to the stages of acute acetaminophen intoxication, in 0.5 to 24 hours, there will be like symptoms like nausea, vomiting, diaphoresis. Some patients can remain asymptomatic. Laboratory studies are typically normal. When there is when the time period is 24 to 72 hours, we can see organ injury like hepatotoxicity and nephrotoxicity can occur. There can be right upper quadrant pain. There can be liver enlargement. There can be tenderness. Aminotransferases can be elevated. Then PT and APTT can be elevated. There can be oliguria, signs of kidney dysfunction, and serum amylase can also be elevated. Then coming to 72 to 96 hours, there will be peak of organ injury. Liver enzyme and function abnormalities peak. There can be jaundice, hepatoencephalopathy, hyperammonemia, renal failure can be there, and death can also be there. Coming to 4 to 14 days, it is a recovery phase. So symptoms and laboratory values normalize, may not normalize for several weeks. Yeah, and histologic recovery lags behind clinical recovery. Coming to lab investigations, so serum acetaminophen concentration 4 hours after the reported time of ingestion in acute ingestions. If the presentation is more than 4 hours after ingestion, a stat acetaminophen level should be obtained. We have to go for AST, ALT, PT-INR, and electrolytes, BUN, creatinine, basic investigations. So if there is suspected intentional overdose, obtain serum salicylate concentration, glucose, ECG, qualitative pregnancy test in females of childbearing age. So basically we have to go for all the routine investigations. Then this is Rumack-Matthew nomogram. So this nomogram gives an idea about the degree of toxicity because of paracetamol. So in the x-axis we have hours post ingestion, and the y-axis we have acetaminophen concentration. So you can see a diagonal line. So if the acetaminophen concentration at 4 hours, 8 hours, 12 hours, 16 hours, 20 hours, or 24 hours after ingestion is beyond this treatment line, So that is a sign of probable toxicity. We have to aggressively treat with N-acetylcysteine. And if the paracetamol concentration is coming below this line, it's likely safe. There is only less chance of hepatotoxicity. So coming to management part, so initially we have to go for airway breathing circulation. Then activated charcoal can be given. It is given 1 gram per kg dose to all adult patients presenting within 4 hours of ingestion. So after 4 hours of ingestion, the activated charcoal is not much effective because it will be absorbed rapidly from the gastrointestinal tract. So but in cases of opioid poisoning, where there is a delay in the gastric absorption, activated charcoal is found effective till 24 hours post ingestion. So those, and we'll come to N-acetylcysteine. This is the antidote of paracetamol poisoning, paracetamol toxicity basically. So glutathione does not readily cross cell membranes. So N-acetylcysteine is a glutathione analog which readily crosses cross cell membranes. The cysteine residue in NAC contains a sulfhydryl group which is capable of reducing the toxic acetaminophen metabolite. So it is effective within 8 hours, less protective after 10 hours, and evidence of hepatotoxicity after 24 hours post-ingestion is also an indication. So when do we use acetylcysteine? If the serum concentration drawn at 24 to 24 hours after an acute ingestion is above the treatment line, as we discussed in the nomogram, suspected ingestion of more than 150 milligram per kg, and there is multiple ingestion during a period greater than 24 hours, and serum concentration is more than 20 mics per ml, or AST or ALT is elevated, and time of ingestion is unknown, and serum acetaminophen concentration is more than 10 mics per ml, or AST or ALT is elevated, there is evidence of any liver injury or with a history of acetaminophen ingestion. So this is the treatment of acetaminophen overdose with N-acetylcysteine. So intravenous regimen, use 20% N-acetylcysteine for each of the doses below an infusion sequence. 150 milligram per kg in 200 ml of D5 dextrose water over 60 minutes, then 50 milligram per kg in 500 ml over 4 hours, then 100 milligram per kg in 1000 ml of D5W in over 16 hours. So total dose is basically 300 milligram per kg over 21 hours. Then coming to oral regimen, the intravenous regimen and oral regimen are equally effective, but if the patient is intolerant to like oral medications, like patient is vomiting, patient is having nausea, patient is having delayed gastric emptying, so we can't use oral regimen, we have to go for IV regimen, but oral and IV regimen are equally effective. So coming to oral regimen, use 10% NAC 100 milligram per ml and dilute in 2:1 in water or juice to make a 5% solution, and initial dose is 140 milligram per kg, maintenance dose is 70 milligram per kg every 4 hours for 17 doses. So total dose is 1330 milligram per kg over 72 hours. So during hemodialysis, in a patient receiving IV acetylcysteine, we administer a dose of at least 12.5 milligram per kg per hour during hemodialysis. So till what time we have to give N-acetylcysteine? INR should be less than 2. AST and ALT are normal or have decreased 25 to 50% from the peak. Serum acetaminophen concentration is less than 10 mics per ml, and patient is clinically well. So this is the modified King's College criteria. We have aggressively treated the patient with N-acetylcysteine. Still the patient is not improving. Patient is clinically deteriorating. So our further management should proceed towards kidney transplant. So this is the indications of kidney transplant. So when the arterial lactate is more than 3.5 millimole per liter after 1 liter of fluid resuscitation, if the arterial lactate is more than 3.5 millimole per liter, and if the arterial lactate is more than 3 millimole per liter after adequate fluid resuscitation, after the tissue perfusion is restored, and also if the arterial pH is less than 7.3, and there is grade 3 or 4 encephalopathy, prothrombin time more than 100 seconds, or INR more than 6.5, and serum creatinine is more than 3.3 milligram per dl. So all these cases, there is poor prognosis without liver transplantation. Yeah. So anaphylactic reactions to intravenous route. So if there is any anaphylactic reactions to intravenous route of N-acetylcysteine, we have to stop the infusion and administer epinephrine, diphenhydramine, glucocorticoid, and albuterol if there is wheezing. And if the signs and symptoms resolve, infusion can be restarted at the prayer rate 1 hour after the administration of epinephrine. So nausea and vomiting can also be seen. Diarrhea is also seen in 50% of the cases. So we had discussed about a case in the start. So patient was given 50 gram activated charcoal and started on N-acetylcysteine. Over the next 24 hours, her ALT rises to 350 and acetaminophen falls to 160 mics per ml, and her acetylcysteine is continued. On hospital day 2, serum ELT peaks and it became 1350 international units per liter, and acetaminophen is non-detectable. On hospital day 3, ALT is down to 350 and acetylcysteine is stopped and she is medically cleared. So this is about paracetamol toxicity. Hope you got some awareness about paracetamol toxicity. So take valuable points from it and subscribe to my channel. So we'll discuss about a new case in the next video. Thank you so much, guys.